Okay, g'day listeners, and welcome back once again to the BroomeDocs podcast and another episode of the First 10 and EM Journal Club with Dr. Justin Morgenstern. If you're listening to this, it means it's July 2024. We're recording this one a little bit ahead of time, which is not our usual practice, just because Justin and I are both very busy young men and we have stuff to do. So, Justin, how are you? What's happening over there in Canada?
I like that in your brain, you're still a young man, Casey. I don't know what the threshold is, but still I'm 1 or 2 years older than you at all times. Sorry, that's not the tone we're supposed to start the podcast off on. We're supposed to be good compatriots at this point. I'm sorry. Things are great over here in Canada. It's hot. It's summer. It actually probably feels a little bit like Broome, 100% humidity and 40 degrees. It's almost
Lovely.
like we're living in the same spot.
I certainly see patients that come in now they're in their late 40s. I think of them as young patients, whereas 10 years ago I sort of saw them as old. Because now I see anyone that's younger than me is a young patient and shouldn't have anything wrong with them. They should just be completely comorbid free and crack on with life. But it turns out the older you get, the less likely that is to be true.
It's not good. I used to it was every time you went to a conference or listened to a podcast, all the old doctors always talked about how age was relative, but the young doctors never did. So the fact that we're talking about age being relative, it's not a good sign in my books, but it's all right. We can move past it.
I reserve to say back when I was a young doctor. I think I've reached the age where I'm allowed to say that now. So yeah, it's all good. Cool. So it's been a pretty hectic month in terms of the evidence-based medicine world. There's been a lot of stuff flying at us thick and fast, and the amazing Critical Care Review conference over there in Belfast took place just a week or so ago, and I managed to live stream quite a bit of it. It was great to do some actual EBM-based conference work. It was really cool. And some really interesting papers come out. And we're going to cover one of those tonight. So why don't we jump right into it?
Yeah, I think no matter what we say about this paper, we'll probably tick at least 1 or 2 people off, but there's a lot to be said. So this is the PreOXI trial. Gibbs is the first author, New England Journal of Medicine, non-invasive ventilation for preoxygenation during emergency intubation. So I think we'll probably end up talking a lot about this from a practical and practice standpoint, which means we both probably think that it's, to at least to some degree, this is practice changing. But there are a bunch of evidence-based medicine points as well. So if people want to put us on fast forward until we get to the practical stuff, that's fine. Evidence-based medicine. So just what they did, this is 1,300 patients, emergency medicine or ICU, all comers essentially. So it's not like they were picking out people who were hypoxic or had COPD, basically anybody who needed an intubation, and they just randomized them in a very pragmatic way. Either we're going to use BiPAP for your 3 minutes of preoxygenation, or we're going to use a face mask oxygen. And one of the semi-complaints is that they weren't necessarily using flush rate oxygen, although it was recommended, and these are sort of high functioning areas. And Weingart has talked to the lead author, and they think, they don't have the data, but they think most people were probably at flush rate oxygen. So basically flush rate oxygen versus BiPAP is the comparison group here, which is an interesting study. Different from ours.
I'll just clarify. Yeah, I'll just clarify that this group of authors is actually the people that have done a lot of the research looking at the first pass success in intubation and the PREVENT trial and all that. So these are people who are very good at airway stuff, it's fair to say.
Yeah, and one of the caveats that we'll get to is that a lot of the intubations are done by fellows and residents. But if you look at it, they have a median of 50 intubations, even as residents. And so, yeah, these people care a lot. I think this is why the author of the flush rate trial, I think, is in the author list here somewhere. So, these people care a lot about this. So I expect the standard care group to be providing very good standard care, probably better than most of us in the community, which is, I think, an important thing when we come back to consider what it was. So that's basically it. You were allowed to, based on PREVENT, you were allowed to use a bag valve mask during the apneic period in either group really, but in the non-invasive group, you just left the BiPAP mask on, set at 10 breaths a minute or a minimum of 10 breaths a minute and an FiO2 of 100. And the reason this paper is getting talked about so much is there was pretty dramatic difference. I sort of like their primary outcome, and we should mention this is a surrogate outcome. It's a monitor-based surrogate outcome. I can hear Ken Milne in my mind, but they didn't choose our standard 90% for desaturation. They chose 85%, which I think is reasonable. It makes it a little bit more clinically relevant because once you hit 85, there's a good chance that you slip right off the cliff and go way down.
Yep.
And a pretty big difference, rounding to 19 versus 9%. So like almost a 10% absolute difference. So almost a number needed to treat of 10, clinically significant. They give us a few other outcomes that will catch people's attention. Desaturation less than 70% was also statistically significant at almost 6% versus almost just a little over 2%. And then cardiac arrest is the one, unfortunately, not enough patients to really say anything definitive, but almost 5 times as many. 1 patient in the BiPAP group and 7 patients in the mask group. That's 0.2 versus 1%. Again, also statistically significant. This was a non-planned secondary outcome, though, so you can put a little asterisk on that. No difference in aspiration risk, which was their big safety outcome. So like a pretty big difference in their primary outcome and in differences in outcomes that we actually care about as well. So you can see why everybody's talking about this. It was published at the time we're recording less than a week ago. So you can see why people are talking about this and talking about it rapidly, although that is in itself a form of publication bias that we should be aware of. That if you get a little too overexcited, you hear about this paper, you would never hear about this paper in the same way if it was a negative trial. I don't know if you wanted to add anything there. I think there's a lot of practical things to talk about, but the evidence-based medicine things that you should know about, because people are going to be talking about this paper for sure. I already mentioned the fact that this is a surrogate outcome. So when you hear a number needed to treat of 10, that's for hypoxia, but most of those patients are not going to have a clinical outcome. So I think you need to do some mental math if you're trying to think about risks versus benefits overall, costs, do a cost analysis. It's not going to be a number needed to treat of 10 because only a small percentage of the patients who drop below 85, 84 for 20 seconds probably has no real outcome for the patient still. So true patient-oriented outcomes will be a smaller absolute benefit than this. And then the big one. We always say be careful changing practice on a single trial. Anyway, we talked last time about that analysis that showed after a single. Now that was single center trials, but almost none of them were followed up with good benefits anyway. So there's reasons to be skeptical, but this is a non-blinded trial. And you might say, hey, Justin, there's nothing as objective as a number on a screen. The oxygen saturation is just sitting right there. But if you said that, you probably have never worked in a resuscitation room because, God, that number is very unreliable. Sometimes it pops on, sometimes it doesn't. Sometimes there's no waveform. You don't know if you trust it or not. But if you're sitting there as an unblinded observer who knows what this study is about, when it pops up and says 92% in the BiPAP group, you might be like, oh yeah, I believe that because BiPAP is supposed to work. But when it pops up and says 82 in the face mask group, you might also believe that, even though those two numbers are flickering back and forth. So I actually do still think there's a lot of room for bias here that I think overall is going to be under considered in the community. These results could be entirely because of bias in sick patients. These are ICU and ED patients. That comes up a lot. So the lack of blinding to me is a fairly big concern. The other thing, we already brought it up, that other people are going to bring up as a big concern, but I'm less concerned about, is just how good the oxygen was in the face mask group. I think listening to Scott's podcast, it sounds like it was very, very good, but there's a big difference. If that group was just, bare minimum 15 liters a minute, if they used a bag valve mask without a PEEP valve on it, if they didn't provide any PEEP, that's very different than doing really high quality preoxygenation. And I think a lot of people will argue, well, of course, BiPAP is you set the machine to provide an FiO2 of 100% and you have a tight seal, you're getting 100%. It's not very surprising that you get less hypoxia giving 100% versus giving whatever you get with a non-root breather. And so I think that will be discussed, but I'm actually less concerned about that than I am about the lack of blinding and the fact that I generally don't recommend a practice change after just a single trial.
That's good. I think there's a lot of blood's been spilt over this, and the points that people keep saying to me whenever I talk about this at work is, well, I'm pretty good with doing Mapleson circuit, or I'm pretty good at doing this, or I'm pretty good at doing that. And that's all good, but you can't answer those questions from this trial. And because you just basically have to look at what their protocol was, and their protocol is a very robust sort of protocol, and it's a pragmatic trial. So these people got what they got, and you can't really go back and say, well, what if we'd picked people better, or what if we'd had a better operator doing it? This is what it is. So that's the beauty of a pragmatic trial, is you see some real world data coming at you. So I would be surprised if any institution just starting out with this process was better at it than what these guys were, just from what we know their experience is. So I think probably the trial shows less benefit than what may actually happen in the real world. I know in my institution, the statistic is that more than half of our intubators have less than 10 tubes under their belt. So in that context, we're probably going to see a bigger benefit if you're spending more time fighting around trying to get the tube in, as opposed to the group who are probably much slicker and the risk of hypoxia is lower. So I think the thing that when I talk to people about this trial, the thing that I keep coming back to is, if we keep it simple and follow a very set protocol, which looks like it's pretty good, in the real world, that's probably better than picking and choosing and trying to choose horses for courses, because I think having one robust protocol that you can follow is better than leaving it up to individuals to decide at an institutional level. But I don't know. What's your thoughts on that? Is that fair?
Yeah, the flip side of that is the argument of diminishing returns and cost, right? I don't actually believe that this is required for everybody. Like the main conclusion of my blog post was, I think, despite being a single unblinded trial, I actually do think that this tells us we should be using this. It's a lot like when we talked about delayed sequence intubation. I think there's no doubt that we should be using that technique. The question is who and when, and who really requires this. Scott Weingart, I keep referring to him as a single name, but I guess we can name him, disagrees with me, and he's arguing along your standpoint, which is, why wouldn't you just make it routine? It's sort of like the bougie thing, like just practice. If you practice on everybody, it's routine. Everybody knows what's happening. But more than that, he thinks that there probably is true benefit from everybody. I'm not sure that we can say that one way or another. I see the argument of just use it on everybody. The flip side is, if you're using it in the way that is described in this trial, there is a pretty significant increased cost, and I would be interested in the actual cost per life saved, because using an actual BiPAP mask and circuit in the medical environment, like, it doesn't seem like that should be that expensive, but all of those do add up a lot. And again, I think the absolute benefit is going to be relatively small. Scott's response would be, look, don't do that. Just use a BVM mask, which you have to have open for every intubation anyway, and get some straps that will hold it on the patient's face. And then you should be facile enough to be able to use a BVM mask with a vent to do these exact same kind of things. You need a vent in the room anyway, because that's the other thing people have argued back to me is we don't have enough room in a lot of our small resuscitation spaces to always have all this extra equipment in there. But if you need a vent, right? Like, that's a thing anyway. So this is the thing. It does require. It may not be as simple. Like, do I have room in a lot of the places I intubate for both a standalone BiPAP machine and a vent? And like, it does complicate things, which always worries me a little bit. So I'm not sure that I've come down on exactly where I am going to argue for our institution on whether this is a for everybody or or whether it's the idea of PEEP is for everybody. I think putting a PEEP valve, cranking it up to 10 to 15, and having a good face mask seal with a few breaths during the apneic period may be providing me just as much, and I can do that with no dramatic changes to equipment in the room. So that part, I don't know. That is a harder debate for me.
I think the simplicity is an interesting argument, because everyone sort of has been saying, it's simpler just to go with the BVM. But I don't know, having a ventilator there already in the room, which is capable of doing both the non-invasive / apneic ventilation and then going on to be your ventilator, it actually relieves a lot of because what I found, a lot of the faffing around is with the APOX is cranking up the flush rate oxygen, then you're trying to put the tube in, and then someone's trying to pull the apneic oxygen away once you've got the tube down. It is a bit of a hassle. It is a bit of and it's something that people always forget, and at the last minute someone's trying to stick nasal prongs up their nose. And so I just think that if we can get rid of the apneic oxygenation, which this trial didn't actually use and showed some benefit, that may be enough to make it more simple in my hands. But I'm not entirely sure. I've got a few other points I thought I'd throw at you, Justin, and just get your thoughts on. the only thing we know that cricoid pressure is good for in the world is probably, of all the trials that have been done into cricoid pressure, it probably had some degree of benefit in terms of decreasing gastric insufflation in patients that were undergoing positive pressure ventilation during the so-called apneic period. Do you think that would be something that would be worthwhile adding into this protocol? So you've got the patient, you push the induction drugs, the machine starts blowing breaths into their lungs. Could you put cricoid pressure on just for that 50 seconds while the rocuronium or whatever's kicking in before you take the mask off and then put the seal on? Like, it's a very simple thing to do. There's probably not a lot of downside to it. We don't know for sure.
The flip side of this argument is this trial may be some of the best evidence that we have that cricoid have. They don't actually state, but they're not doing it because nobody does it anymore. And this is a big RCT, and they had them on BiPAP, and there was no difference in aspiration between the two groups. So what better evidence do you want? That is absolutely pointless and useless. Now, let me back that up, because one of the key evidence-based medicine points that I didn't bring up for this paper was the exclusions. And in a pragmatic fashion, the clinician was allowed to exclude anybody. That's both sides. So you could exclude people who you really thought needed BiPAP, which would therefore decrease the benefit. So I actually agreed with you when you said that you think the benefit is going to be bigger in the real world. Absolutely, because they excluded people who had like COPD or asthma and things like that. But the flip side of that is they excluded almost 250 patients, I think, who they thought BiPAP was contraindicated in. And that's where the concern is. I think this trial, if anything, is going to underestimate benefits, although it's going to be a surrogate benefit. But I think it also significantly underestimates harm, and that's where one of my big concerns here is. Now, you could say, look, we have decades of data on BiPAP, and BiPAP is very, very safe. But take that patient with if you're not thinking this through, because there weren't exclusions, take that patient with a massive stomach full of blood or whatever, and then that's where BiPAP could be a little bit concerning. And look, again, we're talking about a few minutes, and you not walking out of the room, being right in the bedside. But if the flip side of not enrolling those patients at all was putting some cricoid pressure, I don't know. I guess you could make an argument for that, or you could say just keep in mind the fact that this was not all comers. You still have to use your clinical gestalt and adjust to the patient in front of you. That would be my bigger concern, of use it on everybody, because the average person isn't really reading into the details. And then if we start using it on everybody, you could actually see a more harm than we saw in this trial.
Yeah, and that's a really good EBM point, in that the patients that we may really get the big benefit from may have been excluded, or like you say, they may have been, and a great example of that is pregnant patients. Like, if you got someone in late pregnancy, like, that's the person in my head who physiologically is most likely to benefit from generous amount of PEEP as they're in that apneic period, because we know that they de-recruit spectacularly, and there's a lot of risk there, obviously, but they're also the people that we worry about aspiration, so you never really know which way it's going to go. And I think,
to be fair, have you seen an American recently? They're built like late stage pregnancy. Sorry,
ouch.
Should we cut that part out? That's being American. Sorry, guys. I have the BMA stats to back me up. It's just a reality.
And so, like, it's an interesting question, and it would be great to see a trial that included a really pragmatic trial that included all those sorts of people as well. My other question that I've also emailed a few people about is the use of a nasopharyngeal airway, because one of the things that I find is that the crucial step in this whole thing is that if you don't support and keep the airway patent through that minute or two while they're going off to sleep and you're having a crack, you're basically getting no benefit. And I think putting a nasopharyngeal airway into these patients makes sense to me if they'll tolerate it, because it just makes it much easier to hold that airway open, keep it patent, and keep that PEEP pressure on the lungs. And I know that you've had a bit of an argument with Scott back and forth about the whole concept of rapid de-recruitment that happens. And I see this in my anesthetic practice. I really think it is a true thing. And if you have people that, even not obese people, but even just people that are a little bit larger or a little bit older or have a little bit of underlying lung disease, and they just literally, you don't get the tube in on the first pass, or they get a little bit of bronchospasm as you're passing the tube, or it takes 2 or 3 attempts to get the tube in, you definitely see that de-recruitment. And it's quite spectacular in some people unexpectedly. So I do believe that there is a benefit to that de-recruitment in terms of keeping the PEEP as long as possible throughout that intubation period. So that's not based on evidence, but I think it's possibly a thing, and I think the nasopharyngeal airway may help with that.
Yeah, the flip side of that, Josh Farkas on Palm Grid has a great post on getting the practical details. He decided to skip the evidence-based medicine because people are doing it, and said he's been doing this for a decade. And here's his practical points. And his point was routinely, right? You give a paralytic. So for at least 20 seconds, 30 seconds at the end of the paralytic, you're going to get a closed airway. But most people, when you put the BiPAP mask on originally, have an open airway. And you can watch them breathe, and you should be using end-tidal CO2, whatever. We can know that they're breathing. And I found a really interesting point. Like he doesn't really care about a closed airway for the last minute. At that point, the CO2 doesn't matter. And actually, if you close the airway and you already had them on a mean airway pressure of 10 to 15, that pressure can't get out because their airway is closed. So they shouldn't de-recruit because the pressure's already there, right? Like it is what it is. And he says, yeah, occasionally he provides a draw thrust, but he's not worried in those last 20 seconds because whatever, that's what we've been doing. That's what RSI is. So I'm not 100% sure that it's necessary. Again, keeping things simple, but I also like whatever. It's a nasal airway. It's like one of the least bothersome things to patients, and it works really well. And it'll lead in. It's almost like it was a segue, but it's a couple papers down. We can talk about when you should be putting in the nasal airways anyway. There's actually one other practical point that is one. So for me, for pre-oxygenation, there are people who disagree with me, but I'm not sure that if you put somebody on a non-rebreather and their sats are at 100%, there's zero evidence of shunt. And if you want to even argue with me, like take all the obese and the pregnant patients, the people who are going to de-recruit fast out of there, I think this is probably overkill. I've intubated many patients, and for the most part, this is not necessary. To me, the biggest game change, and look, if you were already setting 88%, I hope everybody knows that that's a dangerous situation, and we were already looking for techniques there. The big game change is that people we've overlooked forever. If you put somebody on a non-rebreather at 100% flush rate, and they're still setting like 93%, that doesn't catch an emergency doctor's eyes, but that's the patient that definitely has some degree of shunt, and that we really should be changing our practice on. That was my original thought, is that I don't think we need to do this on everybody. But the thing that might push me over the edge to say, hey, we should probably do this on everybody is oxygen is not the only thing that we're doing. And when we transition patients over to positive pressure ventilation who are sick, that is it's not just our drugs who push people's blood pressures way down, right? The transition to positive pressure ventilation and the decrease in venous return is a big thing. And so in terms of, are you ready for intubation? One of the big things that I've taught for a long time is getting them on positive pressure early gives you a really good idea of what's going to happen after you tube them. And it might let you start your vasopressor before intubation rather than crashing onto it after intubation. So I actually think, that rather than just the 3 minutes, getting somebody on non-invasive while you get everything set up for 10 or 15 minutes gives you a lot of information, not just about pre-oxygenation, but what's going to happen to their blood pressure and hemodynamics. And I think that's a big benefit, not addressed in this study, but one that is worth thinking about.
Yeah, absolutely, and that's been my practice for years and years. Is that you use that 3 to 5 minutes while they're on the non-invasive, and you have an outline, and if possible, and you see what happens to the hemodynamics, and that's a lot of information which I think is often overlooked in the crash intubation of the sick patient. Everyone's worried about the SATs, but that's not what people die of. They're usually the ones that we see crash and burn, as your post would say, it's the hemodynamics that often kill people, and you've got a chance there to correct that. So maybe you can just leave them on for 10 minutes and start the NORAD or whatever you're going to do. So yeah, really, really good point. Cool. I think
one of the most interesting papers in years in my mind. I don't think people should listen to us for the final clinical conclusions. I think the evidence-based medicine limitations will be underplayed in the community because people are going to be excited about this. And honestly, I'm fighting with myself because I have a lecture on basically this up on YouTube. I've been lecturing about this for years. So my pre-test probability or my bias is strong to agree with these results. I just don't know whether it should be routine or whether we should do some kind of patient selection because there is some extra cost, not just even financial, but in terms of mental cost and in the room cost and focus and things like that. So I think that's where the debate will be, and I think people should just listen to multiple perspectives and see where it goes. And I'll close with one. If you're really trying to decide whether this is practice changing, it's weird. We spend a lot of time on this podcast as saying, single unblinded trial. You got to have replication. You got to go. So I think that's important. But the flip side of it, we also spend a lot of time talking about pretest probability and Bayesian thinking. And look, unlike a new novel drug, and we'll get to a couple of those in a second, we know BiPAP works. If you would ask me before they even started this trial, look, is BiPAP going to improve oxygenation in a PreOX favor? Like, yes, like 100%. So if this fits with everything that we know about BiPAP, and so you should have a lower threshold for believing these results than you do, say, for Andexanet alpha or some of the other things that we're going to get to in a few seconds.
Cool. Yep. So I think the bottom line for this one is that this is a tool that you should definitely have in your armamentarium, and you should definitely get with your airway group in your resus room and just work out how you're pragmatically going to do this on the floor when this happens, because it's not something you want to make up on the spot, and it's something that does require you just to change your process a little bit in that peri-intubation period. So get in the room with your resus nurses and everyone else and just sort of see how you're going to do this, because the only way you can really mess this up, I think, is if you try and do something and then you get it all wrong because you haven't got all the gear in the room, or you try something novel that just doesn't work out. So definitely get in there and sim it and try it out, because it does require a little bit of tweaking, and I think it is something that you should have up your sleeve for that patient that we've just talked about who maybe isn't quite so simple.
Yeah,
cool. Let's move on. I will do the introduction to the next paper, because I just know that there's going to be a strong rant coming from the north on this one. So we've talked about this drug a couple of times now, I think, on this podcast, and never in a favourable light, it's fair to say. So the trial that we're going to be talking about is Andexanet for factor Xa inhibition associated acute intracerebral hemorrhage, published in the editorial/advertorial/ New England Journal of Medicine in May 2024. The lead author is Connolly. So I think a couple of years ago we covered this sort of pilot trial of this drug, looking at the reversal of essentially rivaroxaban and apixaban. I think in the northern hemisphere you have another 10A inhibitor that we don't have here in Australia, and these drugs are obviously everywhere. Lots of patients come in having bleeding, and this looks specifically at people that are having brain bleeds as a result of these medicines. And this is purported to be a wonder drug, and the company have been spruiking this as, you know, the next big thing, and everyone should have it on their pharmacy ready to go for when that sick patient comes in with a brain bleed who's already on anticoagulants, and we should be using it. The trial is quite interesting. It's a randomized controlled trial. I'll start with that. So it was randomized and it was controlled. There was a placebo, and it was completely sponsored by the drug company manufacturer and written by the drug company, the drug manufacturer as well. So a bit of a red flag there. It was unblinded, which is, as we just mentioned, in EBM, there's no real reason why this trial needed to be unblinded. Like, this is a drug that you can infuse in a saline bag. So this definitely could have been a blinded trial without any shadow of a doubt. And as we always talk about, the outcomes that we look for in good EBM are patient-oriented outcomes, and this is a sick group of people that had a appreciable mortality and neurological problems as a result of their disease. So really using a patient-oriented outcome seemed like the most appropriate thing, but the primary outcome that they were looking for was essentially biological markers of bleeding. So how big was your hemorrhage in your brain? Did it get bigger or smaller? And then looking at sort of biochemical markers of whether you actually got reversed at a hematological level rather than at a clinical level, which is what we really care about. Having said that, it really wasn't that impressive. So if you look at the primary outcome, which was hemostatic efficacy, it was 67% improved in the intervention group, 53% in the group that got PCCs, which was the control group. And the only thing that really changed was the CT looked a little bit better in the Andexanet group, which is not really something that we care about. And then if you look at all the other outcomes, basically they were down the line, except for all the complications, all the thrombotic events were much worse in the Andexanet group. So you're basically you're taking people that have a hemorrhagic stroke, and you're converting some of them into a person with a hemorrhagic stroke and a thrombotic stroke. That's the bottom line. And you can't really give them TPA at this point, I guess, which is probably the only bright light on the end of the rainbow. So I don't know, Justin. Are we going to be using this medicine in the future? What do you think?
I mean, I definitely won't be, but sadly, we will, because medicine is pathetic and doesn't understand evidence-based medicine. I mean, we allowed, so my hospital's been paying, so I just looked it up. I mean, I can only go by numbers because you never know how much things cost in medicine, but Wikipedia tells me $58,000 US per reversal, this drug. My hospital's been stocking it since the initial trial, which did not have a control group and literally told us nothing. And these things generally expire, every 3 or 6 months. So we're spending hundreds of $1,000s a year to stock this drug that has absolutely no evidence. After this trial was published, which again is a negative trial if you're a clinician reading it, but it's published on the abstract as a positive trial. I've seen 2 emails come out from my hospital about how we're going to better use this in our head bleed patients. So people will be using this because we are pathetic, but this trial shows harm. There is no doubt. And what we have to keep in mind, we have lots of evidence. People always are have trouble reading industry designed trials because they always say, look, they design good trials. And for the most part, that is true. I think this trial shows you that it's not always true. They did everything in this trial that would bias in their favor. They chose not to blind it for no good reason, as you said. They chose surrogate outcomes when they were running a big enough trial that they should have been looking at patient-oriented outcomes. So they did everything that they could possibly do, and they spin this as positive, but read this as a clinician. If I told you that the CT scan looks somewhat worse, but we looked at neurologic outcomes and they're identical.
Doesn't make sense.
What did that tell you? And then everything else is worse. Some of them, they stopped the trial early, which is another thing that is concerning. But we know for sure that thrombotic events are worse, but also MI looks worse. It didn't get statistical, but it looks worse. And they stopped the trial early. Everything looks worse. Death actually looks worse. It's 2.3% higher, absolute, in the Andexanet group. 2.3% increase in mortality is bad. Not statistical, but they stopped the trial early. It's really, really hard to say. Everything is worse in this trial. There is absolutely no reason that anybody should use this. There's absolutely no reason that a hospital should be stocking this. I don't know how we get that through our committees because I think people love new, and unfortunately, I guess there's also a lot of financial conflict of interest. But look, this is a trial that is biased, run by the drug company, and it's negative. We have when it's positive, I have a hard time because we know that these drug companies treat. We have decades of data saying that it's more likely to be a positive trial when it's a drug company trial. And I think you should downgrade these trials. But when a drug company actually publishes data that shows harm, you really got to believe that data. So I don't know. I don't know how you could possibly justify buying or using this drug when the data clearly shows clinical harm. That's all I can say. It's a pretty easy. I don't generally get it as black and white, but there is absolutely no way anybody should use this. I think that is the more research, sure. We're on the edge, but no way, no clinical use.
You can buy a lot of BiPAP straps for $58,000. That's all I'm saying. We're worried about how much we're spending on BiPAP masks, and this drug potentially we would use every day in our emergency department. That's how many people we have with strokes walking in that have this problem. So I
guess the one thing we didn't say is the standard care group has adjusted a lot since the initial trial. Initially we said DOAC's wow, we don't know what to do. Basically everybody here did get 4-factor PCC. So that has sort of become the standard care. And I think that's reasonable. I will note that there's no good evidence that improves outcomes either. So that is still a versus placebo trial that we need at some point. But until we see that trial, I think standard care, not standard of care, but standard care is PCCs at this point, but definitely not the more expensive and more harmful Andexanet alpha.
Yeah. So for the Australian listeners, and a bit of a call to arms if anyone out there has any sort of influence in the pharmacology world in Australia, but when the original trial was published a couple of years ago, it got approval by the Therapeutic Goods Administration in Australia, which is sort of like our government body. But I read it today, actually, and it says it's got a provisional approval pending replication or a confirmatory trial to take place at some point in the future. And this is the trial, and this is total nonsense. So by all rights, the TGA should be ripping this off the shelves. It should no longer be on there because this is a negative trial, which should therefore revoke the approval which was previously granted this medicine. But hey, I don't imagine it's going to happen because I imagine that that's not how politics works. Unfortunately, pharmacology and politics don't often work the same way that we think that they should. So we'll see what happens.
Yeah, I don't really understand how it works in Canada because we have an independent drug administration, and I found it was before this trial came out, but they have a very clear conclusion about Andexanet, which is we should not use public funds to buy this drug. But I don't think they actually have teeth because all the hospitals are using public funds to buy the drug, even though the recommendation is do not do it. So I don't know if anything changes after this trial, but my guess is we will dump lots of money, and actually it looks like potentially hurt patients, which is... Maybe I'm getting cynical. Nobody seems to listen to evidence-based medicine, but if you're listening and you have any sway, I would try to push your hospitals because this is sort of ridiculous.
Yeah, I think what we really need to do is we need the local education of like our hematologists, because this is how this drug gets into patients in my hospital system. Is someone comes in with a head bleed, they're on rivaroxaban, and you call the hematologist and say, "What do you think we should do?" And the knee-jerk reaction is, "Oh, you need to do this," because when all you have is a hammer, everything looks like a nail. It's the old proverb, and I think if you're getting that phone call, like, it's hard to sit there and say, well, we don't have anything to do. You want to do something active to help that patient. But yeah, now we have the evidence. I think we can take a bit of a deep breath and...
Yeah, what I would love, I will never convince anybody to do this, but I would love my hospital to give me the job of evidence-based medicine curator and just give me 10% of what I save, or 5%. Right? If I stop somebody from giving Andexanet and I save the hospital $58,000, give me 5% of that per patient that I stop this being used. And man, I saved the hospital so much money. Why not? And I could retire clinically and just sit there and yell at people not to do things. I can get started on cardiac casts. I can do all sorts of things. Just give me a small finder's fee for everything, every bit of dollar I save the hospital. It'd be great.
I love that. That's really good. A reverse incentive for bad EBM. I love it. What would we do with the money, Justin? Would we like get an editor on to do the podcast?
I'm saying, actually, I think we probably just need to update the host of the podcast. Pay somebody other than us to do the actual work. It'd be great.
Anyway, let's move on. We're getting cynical. Something that may actually make a difference to our patients. And this is an interesting one. So I'll do the intro and you tell me what you think. This is a paper by, well, the lead author is Aslanger, and you'll hear that name a lot in the future, I imagine. It's a new electrocardiographic pattern indicating inferior myocardial infarction. This is 4 years ago now, so the Journal of Electrocardiology. This is something that Steve Smith has been getting very excited about with his ECG blog. So he obviously is a bit of a expert, and obviously is trying to push that envelope towards the idea of the OMI, or the occlusive myocardial infarction, as opposed to the traditional STEMI versus non-STEMI. There's a lot of other types of infarct that people can have, and this is yet another pattern that we all need to be on the lookout for when we're looking for patients that may or may not need to get an urgent cath or intervention. So tell me, Justin, what is the Aslanger pattern, and how are you going to play this in the future?
Yeah, I don't know how we're going to describe ECGs in podcast format, but we'll put a picture up on the website, and you should
Pictures
look. I would recommend going to the ECG, the Steve Smith ECG blog as well, because you have to look at a few ECGs to sort of like burn it into your mind to know how to look for it. I often find Dr. Smith is an amazing ECG technician, but often maybe a little too cutting edge for like the average use. But Amoma too recommended using this pattern in clinical care at a conference I was at this year, which was what prompted me to do this. And I feel like Amoma is like right down the middle of good. If he's saying something, it's at the level of it's time to be thinking about this. So essentially the idea is we all know what to look for inferior STEMI, but like ST elevation is not what we care about. We care about the occlusion of the MI. And depending on anatomy and where the actual blockage is, you can just get a slight change in the vector of the ischemia. That means that you don't end up with ST elevation in two contiguous leads. Basically, the ischemia is at exactly 90 degrees to AVF, so you're not going to get that reciprocal ST depression in you're not going to get anything in AVF because it's at 90 degrees to it. And the end result is that you don't get multiple leads with ST elevation. So the pattern is you're going to get ST elevation in lead 3, but none of the other inferior leads. You will probably get ST depression in the lateral leads, V4 through V6. Technically, the definition is with a positive or terminally positive T wave. And then you should, by have ST elevation in lead V1 that is higher than ST elevation in lead V2. So that's sort of the big thing. The big thing is one lead ST elevation inferiorly in lead 3, and then you look over at V1, and that basically V1 starts counting as the contiguous lead just by the way the anatomy is laid out. If you thought about it that way, we don't generally think about it that way, but right side of the heart and inferior of the heart often go together, and that's sort of the idea. V1 and lead 3, if you thought of them as contiguous, I think that sort of gets the pattern stuck in your brain, and then your reciprocal changes will be out laterally V4 through V6. Evidence-based medicine wise, and so that's what this paper is. It's a retrospective look. It's a really interesting design. So they looked at everybody who had been admitted with an NSTEMI and then looked through their actual ECG patterns and found that 6% of them had this specific pattern. And then they compared those patients who had this pattern to the NSTEMI group, and then they also compared them to a group of patients who had confirmed inferior STEMI. And basically, this group sort of falls halfway in between. So it's not perfect. It's not like the data is like this is equivalent to STEMI exactly. It's also a little bit tricky because sort of what you really care about is angiographic occlusion of the artery. But if you have STEMI, you go to the cath lab right away. If you have NSTEMI, which is what these patients were diagnosed with, you often go to the cath lab a day later, maybe even 2 or 3 days later, and that gives your body time to naturally produce thrombolytics, and so you can naturally reperfuse. So an angiogram is no longer a gold standard, and the people are getting angiograms at different times, which makes this comparison from an evidence-based medicine standpoint very tricky. So probably the clinical outcomes are the most important, and actually mortality with this pattern looks very similar to the mortality in the STEMI group and very much higher than the group who has NSTEMI. So that's an important finding. These are a higher risk clinical group of patients. Overall, if you look at they basically combine the actual angiogram with peak troponin to try to account for the fact that not everybody's going to have a perfect angiogram. And basically, a true STEMI is actually very accurate. They had 97% of them based on their surrogate. They thought had a true occluded artery. It was 54% with this pattern. I think 54% is enough to talk to interventional cardiology right away. I'm not sure what interventional cardiology is also going to be thinking about this because it's not 100%. And, false positive cath lab activations are a thing, and it's sort of 50-50. And so I'm not sure exactly where this will go, but I think this pattern is enough to know about. It's not one where we have the opportunity to just activate cath lab, and then we have the second pathway is call cardiology and discuss. I think this is probably in the second category, not the first. Just automatically activate unless you talk to cardiology ahead of time and they're like, yeah, we agree, we're going to take this because we're not concerned. But I think you don't want to go to the third category, which is what we've all been doing, which is NSTEMI, admit with some aspirin and Plavix or whatever, and let the team figure it out in the morning. I think it is the middle category right now.
Yeah, I think that's a pretty good summary. I just wanted to clarify on that when you said that this was sort of in that intermediate range and the mortality rate was similar to the STEMI, you mean it was similar to inferior STEMIs as opposed to all STEMIs if you take big anterior STEMIs, which obviously have a higher mortality. Yep.
Correct. The only comparison here is to inferior STEMI. They didn't have any other comparison group. So we're talking about, I can't even see long-term mortality, 11% versus 10% kind of ranges, whereas the NSTEMI group has 3%. So, cool. Still, a mortality you're not going to scoff at, and it is triple the NSTEMI group. So I think that's very important to know. And in fact, no, I don't think it was statistical here, but this group, this ECG actually had slightly higher mortality than the true STEMI. That may be a true finding. It might just be stats, but I could believe it's true because if these are STEMIs or occlusion MI and we're not treating them as such and just giving them a cath 2 or 3 days later, it makes sense that they might have bad outcomes. So we might be able to bring that mortality rate down if we actually started sending these patients to the cath.
Yeah. I think we should rename inferior STEMIs because they're not inferior. They're the one that you want to have if you're going to have one. I'd much rather have an inferior STEMI. It should be called the superior STEMI or the preferred STEMI if you're going to choose one because it's not inferior at all. That could just be me. My gut feeling with this, I'm old, as we discussed at the start of the podcast, and like I grew up on CKs and going through that process. And the STEMI non-STEMI sort of binary thing was sort of something I learned later in life. And now we've got so many of these new patterns that we have to be on the lookout for. And Steve's done a great job of putting them all out there on his blog. And the OMI versus non-OMI is really a good way to think about it. But I really think it's time to change the way we approach this and change the way we teach it in particular, because as long as we keep teaching this sort of STEMI, non-STEMI sort of binary phenomenon, I don't think we're ever going to win this sport. Like, cardiology is just going to be too hard. I think we have to accept that there's a lot of variations here, and a lot of it comes down to subtle nuance. And I don't think that memorizing 50 separate patterns which are slightly higher risk than one another is the way to go. I think we need to, one, look at the patient, and two, look at the patterns and have that process within your team ready to go, because it's really tricky. And like, I've certainly seen a lot of bickering back and forth between cardiologists and emergency doctors over the years over what really represents a true risk situation, what doesn't. And obviously, if I see this pattern in a 40-year-old who looks really sick and is sweating bullets, I'm going to call code probably. I'm probably going to call the code STEMI team. Whereas if I have a slightly demented 90-year-old that I see this in, I'm probably just going to call cardiology and say, what do you reckon? So you need to be a physician. I don't think. I think my brain is full, and I think a lot of the listeners' brains are probably full of these sorts of subtle variations, and we just sort of need to accept that the whole dichotomous situation doesn't really exist. It's not a thing. The OMI language is useful, I think, and we just start going down that pathway more, but accepting that it isn't black and white. There's no hard line in the sand. There's subtle variations and gradients that exist in cardiology, as is everything else. And I think the acceptance of that will probably make those conversations on the floor a bit easier as well, because it's not like an all or nothing phenomenon. Yep.
I'll say something probably controversial and maybe very surprising out of my mouth. And I don't want to let cardiology off the hook for making these decisions, because unfortunately, the more tests you have, the more it falls on our shoulders. But I do think that this is the one area that CT coronary angiogram may actually end up being beneficial. We've been dumb so far. We've been using it in zero risk patients. I mean, I haven't, but some people have been trying to push it in that sure. category, and it makes no sense. Zero risk or stress test type patients don't need anything. But in this, when you're right on the edge, if we switched away from STEMI, no STEMI, to OMI or non-OMI, the question is there obstruction? And all of a sudden, especially if you can get the perfusion, I've seen many examples, and Steve Smith's blog is a great example of this, where you're like, you look at the heart and it's like there's a clear large segment that is not getting perfusion with contrast, and you're like, oh, we know what's happening. And so when you have a borderline ECG, rather than having to flip it, like I think it's reasonable, and I don't think like the system should ever be penalized for just bringing these patients to the cath lab. The ideal world is cardiologists who really want to see sick patients and get involved, but you do still have to triage a little bit. And I think not every hospital has a cath lab. Not every hospital is a 12-hour flight like Broome. So me in the community where it's a 30-minute drive to the cath lab, but I have the capacity to do CT angiogram, I think there is some role of differentiating that would require probably a study in the future. But I think that is where the study should be done, not in the low risk patient, but in this population, there may be some benefit.
So what you're saying, Justin, is we should, instead of being arguing with the cardiologist, we should be arguing with the radiologist. Is that about who gets the scan? Yeah. So that's
I'm a classic emergency doctor. More CTs is always better. That's what the radiologists think about us, at least. We love our CTs.
I know that's a really good point, because even some of the more remote places like in Broome, it's actually really easy for me to get a CT. Like I can get a CT in 20 minutes pretty much without much hassle, because it's usually sitting there idle, ready to go if I've got a sick enough patient to put them in. So it's a useful argument, and maybe something that we will do in the future rather than just accept. Because what tends to happen in remote places is the non-STEMIs, say, sitting in the hospital for 48, 72 hours on Clexane. As you know, we love using Clexane in our non-STEMIs. And then they get an angiogram sometime the next week, which there's a proportion they're going to be in this group. And unfortunately, they're not going to do as well as maybe they could have done if we'd proven early on that they did have that non-perfused area of their heart.
Yeah, the NSTEMI patient is one of the ones that actually scares me the most, and it really is not the emergency department's job because it does fall under whoever the admitting team is. But I think we do a really bad job, and we even do a really bad job based on guideline care. Because if you read the guidelines, yes, there's a distinction between NSTEMI, STEMI, but they all have this line in there that is like, if there's indications of ongoing ischemia, they should go for immediate emergent cath. So if the patient has ongoing chest pain, you're supposed to transfer them. Nobody ever does. If they have a rising troponin, you're supposed to transfer them. Nobody ever does. I think it's an area where we get under aggressive because as soon as they flip that switch to just inpatient care, they're not emergent anymore. Our brains get turned off, or it's just harder. Like when it's a clear STEMI, it's easy to convince somebody to take it because there's a set protocol. They're having ongoing chest pain. Is it ischemic? Is it not ischemic? All of a sudden, there's a huge judgment overlay. But I think we forget those lines in the guidelines that these patients, if we really believe there's ongoing ischemia, they should be in a cath lab, and we don't do that. It's just not how it works. And if there's not ongoing ischemia, I don't think they need an angiogram at all. There's pretty good data on that as well. But they all get an angiogram. We just do it at the wrong time and in the wrong patients. It's sort of problematic.
Cool. All right. I think with that, we'll move on to the next paper.
You're going to make fun of me for this next paper, aren't you? Like, I'm pretty sure you have all the skills. You're an anesthesiologist. You're just going to be like, Justin, you're absolutely pathetic. So let me introduce it, and you can tell me how bad I am at life.
I will preface this by saying it is the hardest tube in any resource, but carry on with your confession.
Yeah, honestly, I think I am. Everyone thinks they're good at things, but I like procedures. I work in departments where everybody's worried about doing an LP, and I'll jump in and do it for somebody else. I like procedures, and so therefore, I think I'm relatively good. And man, I fail at NG tubes like constantly. I don't know, even an OG, the endotracheal tube's already in. I can't get it to pass. So that's why this paper jumped out at me. But it also jumped out at me because I love RCTs of relatively simple topics, and that's what we have here. So the paper is Wang in the BMC Gastroenterology 2020. It's a pre-installed nasopharyngeal airway in the right nasal passageway to facilitate nasogastric intubation in anesthetized and intubated patients, a prospective randomized control trial. Really simple little RCT. I love it. I think it was only one anesthesiologist who did all of the procedures. Like he ran the RCT himself, which is interesting, but great. And basically, very, very simple. You put in a nasopharyngeal airway, so the kind that we're trying to do for airway obstruction, and put the NG tube in through that so that it's directed towards the esophagus, or you just do the NG exactly how you were supposed to. Obviously, that's not blinded in any way. For some reason, in my notes, I don't have many patients were in this trial, but it's a small
it wasn't big, no.
Yep. Yeah, but the outcomes were like dramatic. So like first pass success was 83% versus 47%. Success after 2 attempts was like 90% versus 65%. Statistically significant. I actually didn't look up the question that you asked me about which one was faster, and I can do that while you're talking. But basically, a non-perfect trial, but like a pretty big increase in success rate for a procedure that I know at least me and I think a lot of people do struggle with. And it seems like a low cost, like very simple tip. But I was a little embarrassed to bring it up with an anesthesiologist who I'm sure you're going to just laugh at me. So you do tell us our thoughts on how I should be doing this, and I'll look up the stat I wanted to look up.
Oh no, I think it's a huge problem because everyone always high fives. They got the tube in, they put the outline in, they put the central line in, everything's gone in, and then you're trying to get the patient off to CT, and usually the radiographer's standing there going, "Oh, do you want me to shoot an X-ray to check your tube position or your central line position?" And everyone's like, "Oh, we've got to put the nasogastric in. We better throw that in quickly." And it's never quick. It usually takes a lot longer than everyone thinks. And I reckon it is the hardest line to put in a resus, particularly in the intubated patients. So I just find that figure of 47%, so less than 1 in 2 were getting it in on the first pass, which just seems really low to me. Like I don't know.
It's high to me. That's okay.
Maybe it's just me. I've been doing this a long time, and these are my sort of patients. So these were not emergency patients. These were elective abdominal surgery patients, and maybe that's the trick here. Is usually the scenario is that the patient's having their gallbladder out, and you've just intubated the patient, but because you've bagged them a little bit through the apneic period, their stomach's blown up, and then the surgeon puts the laparoscope in and they can't see anything because there's this giant stomach bubble sitting in their way. So they say, can you put a nasogastric down? And there's like 20 people in the operating theatre standing there watching you, so they can't proceed with the operation until you've deflated the stomach. So usually there's a bit of pressure on. So I think you get better at it in the heat of battle like that. I don't know, but I've got to say I've never done this technique. I can't remember the last time I couldn't get a nasogastric tube in, to be honest, Justin. I'm usually like the third person in the queue that does it. Like, so the airway doc tries it, and then they get one of the other people to do it, and then I come in at the end because it's usually the order of merit in my department. I find that the finger is the way to go. So this is my technique is pass the tube, have my finger in the patient's mouth, just feeling and guiding the tube into the correct position. And you can get that automatic biofeedback where as soon as it starts to bend or kink a little bit, you know you're in the right place. So you just adjust it a little bit further down. To be honest, I very rarely fail. I've certainly seen the technique where people actually pass another endotracheal tube down the oral route, and that will always go down the esophagus because the trachea is already taken, and then you pass the tube down there. But this is probably a bit simpler and less traumatic to the patient, I imagine. So, give them some propofol before you do this.
Yeah, because I'm not doing anything in the operating room, most of the time when I fail, I can just leave it to the ICU, and I don't give it that many attempts. but where I extrapolated, these are in unconscious patients. So yeah, I agree. I've used the technique where you shove your finger way down their throat, and you can guide it a little bit. But in the awake patient, or the patient who I want an NG tube before intubating the full stomach, that's where I was sort of bringing this in my mind, and I definitely will try it. I have not tried it yet, because those patients, you can't go sticking your finger all the way down the back of their throat. It just doesn't work. You can help guide them a little bit, but the idea, like it's a lot like, to me, the intubating bronchoscope has always been fascinatingly easy, because once you get it around the corner at the back of the nose, it just seems to want to go straight towards the cords. That's just like there's something about coming around the corner at the back of the nose. I imagine this is why blind nasal intubation used to be such a thing. It's just like that curve sort of wants it to go. But the idea of having this just directly cord, instead of going into the mouth, which is where it sort of wants to curl up often, down back into the nasal, into the pharynx, is interesting. Now maybe it'll go towards the larynx and the vocal cords, which is less than ideal, but it makes some sense to me. And I think it also, like, either way, you're going to have some pain going through the nose, but I think this will allow the patient more comfort if I have to do 2 or 3 attempts, because now I'm not jamming it through their nose multiple times. The conduit is already there, and so the painful part of going back and forth with the NG tube should be taken out. So I'm interested in trying it. Yeah, again, I don't believe that this is going to be a 40% absolute benefit from this, but as little tips and tricks, maybe we've already talked way too long about a paper that's just a little tips and tricks RCT, but I thought it was a neat little paper, was basically all it was.
Yeah, I think I'm just looking at the time, because I'm pretty sure that it was quicker to do it the old-fashioned way without the NPA, and
yeah, you're right. 30
probably
seconds,
the only.
Yeah, 30 seconds longer, although I'm not really sure how that could possibly be the case. And maybe that explains all the differences, because the NPA was there. This one doctor was willing to spend more time on it, because it does not take 30 seconds to put in an NPA, and otherwise everything should be identical. So I have a hard time explaining why it would take longer to do this procedure with an NPA.
But I guess if
we could find an NPA standing around the room for it.
Just from an ABM point of view, though, you have to remember that if it takes, that was 30 seconds longer to have the first attempt, but if you miss twice with your old-fashioned attempt, it's going to take you a lot longer. So maybe the MPA will save you some time in the long run. So hard to say. It's a good trick to have up your sleeve, and of course the old-fashioned way of fixing this is you tell the medical student that's standing nearby to re-intubate the patient, and it always goes in the esophagus 100% of the time. So then you know where to go. So oh, it's so harsh. Anyway, we'll carry on. Move on to the next paper. Do you want to do the intro on this? Because
Yeah,
I
this
went
was
down a bit of
your.
yeah, I went down a bit of a
You went
rabbit
on a
hole.
rabbit hole of methylene blue. I will admit that I have never bothered to get deep into the evidence-based medicine here, and that may be an individual bias. I think there was 3 total patients during my ICU training time that we tried, and they all died within 48 hours. And I think it's because you use it at that end stage. It's a last hope thing. But I never had a fuzzy, warm feeling about methylene blue as a treatment idea. And I also had never really come across a high quality paper, which I think we're going to find out is probably because there are no high quality papers. But you sent me over this meta analysis. It's by Pruna just this year in the Journal of Cardiothoracic Vascular Anesthesiology, which is a journal that I'm sure everybody subscribes to. 2024 January. It's methylene blue reduces mortality in critically ill and perioperative patients, a meta-analysis and of randomized trials. Reduces mortality. That's pretty big, Casey. Why did this catch your eye? Why do you want to tell us about it?
Well, the reason it came up is we actually had a super sick patient, and we actually was part of our M&M process in our emergency department where we went through this. And part of it was the advice that we got from the intensivist, well, we should have a crack at some methylene blue. As you say, in that Hail Mary, we've given them lots of vasopressors, we've given them some steroids, we've given them some vasopressin, and everything else didn't seem to work. So let's try methylene blue, because we had it on the shelf, and it was one of those things that was suggested that we try. And at the time I was thinking, why haven't I been doing this my whole career? Because I've seen plenty of super sick septic patients, and if it is such a thing. And then I read this paper when I was doing some research for our M&M meeting, and the title of this paper just jumped out at me, because I'm like, reduces mortality. Wow, that's a why aren't we all doing this? And I had that sort of cognitive dissonance in my mind where like I read a lot of EBM, I read a lot of stuff that you send to me, and yet I was unaware of this mortality reduction. It seemed like an odd thing. So I started doing some deep dive into this, and this meta-analysis, and they're actually, I think there's about 4 or 5 meta-analyses that have been published in the last couple of years of methylene blue trials for septic shock and for post-cardiac surgery vasoplegia, the 2 main groups that get it. And there's almost as many meta-analyses as there are trials, and there's almost as many trials as there are patients in the trials. So I was trying to coin the term Morgenstern's malady, where there's more meta-analyses than there are actual trials, because I think that should be a red flag for any intervention in medicine, that we just need more data, basically. And if you look at the picture here, if you just exclude all the post-surgical patients and just look at the trials that looked at septic shock patients, which are the ones that I really care about, the numbers were really small. So most of the trials are sort of in that sort of 20 patients in each arm. A lot of them are blinded, but unfortunately, can you really blind an intervention where the patient turns blue and the urine turns green and the SATS probe stops working? Because that's what tends to happen with methylene blue. And
I don't know why they even claim to be placebo or control or blinded. Like, why unless they're using indigo blue as is there a different dye that you can, like, what would you use as a placebo in these trials? But they claim it. Like, I'm perfectly fine just saying we couldn't blind it because it's freaking methylene blue. But like, why? Why are you saying that? Anyway,
it's interesting. I'll come back to that point. And these are all very small trials, and pretty much, well, actually, I can say all of the trials use monitor-oriented outcomes. So looking at the map, or looking at the dose of norepinephrine that was required after the methylene blue had been infused. And they used a whole heap of different ranges of doses and everything. And that's fine. Like if you're in that true Hail Mary situation and the map comes up 5 points, that's a win. Great. But publish a trial then, and publish your title should be methylene blue increases the map in critically ill patients, because that's what all of these trials showed. And a lot of them didn't even have mortality as an outcome. Like, it wasn't even something that they measured, or if it did, it was such a small number that there's no way they could prove it was one way or the other. And so I was really shocked when a paper managed to get published in a journal saying it reduces mortality, when none of the papers included in the meta-analysis actually included mortality as an actual outcome, and definitely didn't have the power to calculate any sort of mortality benefit. So that was the main reason I took umbrage with this paper, because I just think that it's a misleading title. And if you're the sort of person that just reads the abstract or skims the titles, you could walk away thinking, yep, this is something we should all be doing. Obviously, methylene blue is a pretty cheap drug. I don't think Big Pharma's in on this, but it's not the way medicine should be done. And this is certainly a disease where there is a high mortality. We're already doing huge trials on septic shock patients. So this is something that could very easily be done on a big scale, so that we could get to that. So interestingly enough, I got into a bit of a Twitter. Am I allowed to call it? I'm old. I'm allowed to call it Twitter. Debate where I actually had a chat with one of the authors of the most recent trial, which is the largest trial, Dr. Ibarra Estrada, who is from Mexico and is a lovely chap. And we had a nice little back and forth over the email. And he's actually doing another trial at the moment, looking at the intervention where they use methylene blue early on in sepsis, so not waiting until that Hail Mary moment where their fingers are already dropping off, and actually using it earlier on. And that might be a very interesting trial to see if we use this intervention sort of before we get to that point, whether we can actually turn the patient around, because we don't turn many patients around when they're at that end of the disease spectrum. So that may be where it has its benefit. We don't know yet. We have to wait for the trial to come out, although the hint was that trial was going to be published at some point. I went through clinicaltrials.gov, and unfortunately there's quite a lot of methylene blue trials in a lot of different patient populations that have never been published. And that's a bit of a red flag as well. So a lot of small trials that were never published, that's that publication bias. So people doing trials, not showing any benefit, not publishing. And that's a bit of a problem in evidence-based medicine, particularly in this group of patients. The biggest trial that's ever been done not with methylene blue, but with another drug that basically has the same effect as methylene blue and nitric oxide synthase inhibitor, actually showed an increase in mortality and was stopped early due to harm. So, and that had 770 patients or something in it. So twice as many patients as in any of these methylene blue trials. So you got to really wonder, is this really a harmless intervention or something that we can just try as a Hail Mary when really all the best data would suggest maybe not, and we really do need a big trial before we start saying this is ready for prime time. But I did take a bit of caution with the title of this paper. I just think that's a misleading title, unfortunately.
It's a little bit of a tangent, and I think I probably had this rant on the podcast before, but one of my big concerns, and I think I'm at odds with lots of people in the emergency medicine and critical care world, but I think the idea of the kitchen sink is just so misguided from a basic logic standpoint, right? We wait till the end of the line and then we just, whatever, at this point, because the patient looks really, really sick, evidence-based medicine doesn't matter anymore. Just throw everything at the patient. And I think that is just exactly the opposite and wrong thing to do. Because overall, the standard emergency or standard EBM logic is that benefits will change based on how sick you are at baseline, but harms are sort of static across the board. But I think that ignores the critically ill patient, because very subtle changes in physiology can really push a critically ill patient over the edge. And everything has harm. And so the idea that you just throw the kitchen sink at somebody, an unproven medication because somebody's critically ill, I think is really misguided, because I think you can do a lot of harm by doing that. And this came up, I think the last time we talked about it was that COCA trial, calcium in dead patients. You don't think you can do harm to dead patients, but they had worse outcomes. So throwing things at people just because they're sick, I think is a bad call. We're not set up, but what we really should be doing is if it's something that we think we should be throwing at sick patients, it should be done in a randomized fashion. We should be collecting data from it. But yeah, I'm excited. If something has physiologic basis, and we do see it, like in the patients I've used it in, their monitor looks dramatically better for a little while. There could be something to it, but use it early. Same thing with intralipid, for example. We use it at the very end, and it probably doesn't work. But if it's really a good idea, use it up front in an RCT and see if it actually does something. So yeah, at this point, look, am I going to argue with an intensivist if they say, hey, I'd like to try methylene blue in this patient? No, I guess that's fine. Like, it's up in the air. There is this meta-analysis that says mortality benefit, but should we be using it routinely? Should this really be part of clinical care? No, absolutely not. This is at the point where it's a good hypothesis and somebody should be running good RCTs on it. It sounds like somebody is, so that's good. Maybe we'll talk about it more in the future.
And I may get myself in trouble for saying this, but last podcast we talked about the multi-center versus single-center RCT trial, which showed that it was like 1 in 20 of the mortality benefits in critically ill patients were replicated when looked at a multi-center level. So this is 5 small single-center trials which have all showed some sort of monitor-oriented outcomes. But what this really needs is a big RCT so that we can look at this across multiple centers. And, we just need a big group like ANSCIS or someone to grab this and run with it and do a 2,000 patient trial and see what actually happens. Unfortunately, one of the authors that was on this trial was also one of the authors on that other trial that we discussed last month, talking about how you can't generalize small single-center trials into multi-center trials because they can't be replicated. And it's frustrating when you see that in medicine. So that was one of the reasons I really didn't like this this conclusion that was drawn from this meta-analysis. So I think we definitely need...
when you can't because like citing your own papers, it helps increase your citation factor. So you should be able to cite that thing and say, look, these are really interesting hypotheses, but from a clinical standpoint, be cautious. You think you'd be able to write that in? Because I don't think it takes away from your systematic review and meta-analysis. But what do I know? I know that journals like... as much as they say they're about science, journals like big attention-grabbing conclusions and headlines, and I think that's one of our bigger problems in medicine. Is it's not driven by the scientists and researchers themselves. It's a little bit driven by the journals of what will be accepted and published. It's a little bit like CNN or one of the big newspapers is driving things because that's what matters is headlines, and that's a little bit sad, but a true reality if you're a researcher.
Yep. So bottom line, we're not saying this doesn't work. We're just saying we don't know. We need more data and we need some big, nice trials. And this is completely doable, apart from the blinding. So carry on. All right.
I don't know how we've done it. We only had 6 total papers. We've only done 5 so far. We're already over an hour. So I don't know. We were going to take up the exact same amount of time with half the number of papers because we're just
I don't know. They were quite rantogenic.
But I guess we can finish off with a lot. I don't think we should have to spend too much time on this one because it seems a little bit ridiculous to me using a antiviral medication to treat long-term symptoms like 3 months after a viral infection. But this is another Paxlovid trial published in JAMA Internal Medicine 2024, the STOP-PASC trial. Paxlovid, I'll shorten it, and symptoms in adults with post-acute sequelae of SARS-CoV-2 infection, the STOP-PASC randomized RCT. Honestly, there are a lot of people struggling with long-term symptoms after COVID. We'll come back to it, but one of the hard issues we have right now with running any trials is we don't understand it well enough to know, whether is this one set of pathologies, is this a bunch of set of pathologies, what's the underlying pathophysiology, how do you design a drug to treat something that you have absolutely no understanding of and absolutely no gold standard for is a little bit tricky. But in this trial, they took people who had only 155 patients, but people had to be at least 90 days after a confirmed COVID infection, and they still had to have symptoms that a treating clinician thought were due to long COVID. And they just compared Paxlovid versus placebo, and it is a dramatically negative trial. No difference in anything here, which I believe, because they put forward a theory that long COVID could be due to ongoing low-level viral replication, but it seems way less likely. Of all the theories, whether it's psychological or immunological or inflammatory, that seems like the most unlikely. Plus, this is a quote-unquote antiviral that hasn't actually shown to do any antiviraling in even acute phase of the infection. So if it doesn't work in the acute phase of the infection, I think it was very, very unlikely to work in a potentially chronic phase of the infection. The only thing I'll mention, they don't find a adverse event difference, but we've talked about this more and more, but this is the most ridiculous example that I've ever seen by a definition of adverse events. 99% of the Paxlovid group had an adverse event, 93% of the control group. What definition are you using that 100% of patients are having a fucking adverse event? Like it is insane. And clearly you need to refine your definition, but that is a 6% absolute difference. So there is almost certainly a difference, and they're just hiding it in a ridiculous definition. Anyway, my quick conclusion is clearly Paxlovid should not be used for long COVID at this point, and probably shouldn't be used for anything at this point. But I don't know if you had any other thoughts other than that.
No, it doesn't really make any physiological sense to me. And it's kind of like, if you think of like shingles, right? Like someone's got shingles and you put them on some valacyclovir and it doesn't really do too much, but it might stop them getting postherpetic neuralgia. But you don't put someone on an acyclovir tablet 3 months later hoping that it'll clear up their the horse is bolted, like it's causing some
it's like
sort of
having
systemic...
somebody with post-herpetic neuralgia. So is that their chronic pain stage 6 months later and putting them on Valtrex at that point? That doesn't make any sense.
Doesn't make any sense.
That's where I thought this paper was. And unfortunately, and I don't want to downplay it. Obviously, there are a lot of people suffering, and there's some mixed evidence on how much is psychological versus a more physical pathology. And I think it's probably a mix of both, but we just don't understand it. So I don't know how you even pick a chemical or a drug or an approach. And I don't even know how you enroll patients in these trials, because they're likely to be so mixed. And I don't know which symptoms are from quote unquote long COVID and just from life or from stress or from anything else, right? It's really, really hard to pick that out. So it's going to be hard to run a good RCT, but I do think that researchers need to keep doing it, because it's not like there is a significant minority of the population that's having ongoing symptoms. My guess is that you can roll over some of the research that we've done in chronic fatigue syndrome or other things like that, because it's likely to be similar, but I guess we honestly just don't know.
Yeah, I guess the only sort of interesting evidence-based medicine point on this, I think, is that obviously Paxlovid's a combination medicine, which is two antivirals essentially, but nitramlamivir is the one that's supposedly active against the COVID infection, and the ritonavir is actually really just there as a blocker of the cytochrome system to make the other drug more active, and that's how it works with the HIV sort of pack that you get with the heart. But they didn't actually do a total placebo control, because people in the control group actually got the ritonavir, which still gives you the side effects. And I have a little bit of a problem with the ethics of that. Are you really in a placebo control group if you're getting a drug that gives you a funny taste in your mouth and makes you feel a little bit crappy? I don't know. Like, it may help with the blinding, but is it ethically the dumb thing to do that if you knowingly given patients in a placebo group side effects?
Yeah, I mean, honestly, I think that might be the right way to run the trial. I don't know that I thought through the full ethics of it, but a big part of ethics when you're talking about research is designing a trial that actually gives you an answer. When you're talking about like the outcomes here, by definition, we're going to be very subjective, right? They're how people feel. So it is a trial where blinding really, really, really matters. And it doesn't take very long to read about Paxlovid and know that you're gonna get bad taste. That's just what it is. And so if you got the bad taste, you would expect your symptoms to improve, and if you didn't, you didn't. So I think if you ran the trial the other way, you would almost be guaranteeing some subjective improvement, because I think that's something that's easily searchable by patients. And being in an RC or being in science doesn't guarantee you that you're not going to come to any harm. There is risk. That's why we do informed consent. So I think it might still be the right way to run the trial, but you raise an interesting point, because it's not one that we've ever seen, right? Active ingredient placebo is a really interesting concept. But I think, honestly, there are lots of reasons to be doing that in other trials, because we talked about it with methylene blue, but there's lots of trials where you're like, yeah, they say it was blinded. Even to go back to the TPA and stroke trials, they say it was blinded, but all the nurses knew what group you were in when they were starting their IVs and you were bleeding. Anyone who saw your labs knew what group you were in. So all of a sudden, it becomes a little bit more questionable in terms of the underlying science. And I think that one example points to the potential harms, because decades later, you still don't know what the hell you're doing, and you're potentially hurting everybody because you don't know what the hell you're doing. It's an interesting dilemma on exactly what degree the ethics comes into it, because the ethics of running a trial that doesn't give you a good answer are really tricky as well, because then you enroll these patients for no good reason.
Cool. One more rant just before we finished is I ranted about the title of the previous paper because I thought it was misleading. But even the acronym they've used here, STOP PASC, which is Stop the Post-Acute Sequelae of COVID, like, the title of that, basically, if you're someone that just looks at this, you just look at it and go, oh, this must work, because the title's called Stop PASC. And I just think that you can't use an acronym like that, which looks like a really positive. It's not a neutral sort of title for a trial or an acronym. So they should be question mark, at least a neutral title, rather than, yes, this stops PASC, because that's what, when you read this, you think, oh, that's what it's going to do, but it doesn't do it, obviously.
You want all trials when they're pre-registered to have the question mark, and then when they actually get published, they're allowed to take the question mark away, or they have to add doesn't at the beginning. This is doesn't stop PASC.
I would much rather if the acronym that they used in the trial spelled out a dirty word rather than like had an orangutan or something, rather than have some sort of non-neutral sort of like, this is what we think is going to happen with our medicine, because that's the problem, is that people skim this and like you say, it goes across the bottom of the ticker tape on CNN and people go, oh, this stops PASC, when it doesn't. So I'd like to see the title of the trial at least be neutral. So cool.
Yeah.
All right.
I
think that's about it.
I think we made it. That's exciting. It's only an hour and 20 minutes for 6 papers, so you can do the math. It's I think we're doing good. Eventually our podcast will do 1 or 2 papers and it'll still be 2 hours, and we'll see if people actually, that might be where in September we can advertise. I think we're going to do a journal club, and so yeah, that generally, I don't know how many papers we're going to do, but we'll really slow ourselves down. It'll be great.
Yeah, no, I think putting us in front of an audience, which is what we're going to do in the September edition, it can't help. It's going to go backwards. It's going to go the other way, and there's probably going to be more beer in.
The other side of the argument is anything has to help, because I know our baseline. We can't get worse. So it's okay. People still listen. Cool. I don't know. I think it's some people. I don't have your stats. At least 100 people listen on YouTube, so that's good.
That's better than that on the podcast side. I think we're better on the audio than the visual version for sure.
Yeah. I mean, well, we haven't actually started recording. If people actually want it, they can tell. We could start making this one of those fancy podcasts that all, like, the celebrities all have the podcast there. You can actually watch them on YouTube talk back and forth. I don't think we want that, but if the audience really reaches out, we're willing.
Just
I don't know what it is.
Justin at first 10 a.m. if you want to see his moniker up on YouTube.
You leave some comments on YouTube. If it gets a lot, I'll buy Casey a nice camera and we can put it up on YouTube. We just need some subscribers to support it. And then we can get an editor. We can be big time podcasters. Like, I don't know any of the famous podcasters, but Joe Rogan, you look like Joe Rogan a little bit. It'll be okay.
Well, the problem is that we have to be better than the cute looking dog with the spectacles that you currently have up on the YouTube feed. I don't think
that's true.
Yeah, it's hard. It's a hard act to follow. So yeah, cool.
Yeah.
All right, mate. Well, I'll talk to you again in a couple of weeks, and we'll do this all once again in August. And have a great summer over there. Hope you get out and get some sun, hit some golf balls, hopefully not into lakes, and enjoy your time.
Enjoy your holiday. We'll talk to you next time.
Bye.